So my name is Tatum Corin, and I am the Assistant Dean of Graduate Medical Education at LAC USC, the County Hospital, and Keck University Hospital. I have several years of experience in graduate medical education, residence as teachers, teaching in the clinical setting, and this presentation is one of my favorites to do. What we're going to talk about today is teaching when time is limited, specifically looking at the 1-minute preceptor as a model that you can use in a busy clinic setting. What's great about the 1-minute preceptor is that it allows you to assess the learner's needs, do a little teaching, and give some feedback, kind of all rolled up into one. That makes it the ideal model for clinical teaching for preceptors. So one of the questions I often ask many of the individuals that I work with is, how many of you supervise medical students or residents or trainees? And almost every hand goes up, hence the point of the training. But what often is the catch is I ask, how many of you have formal training in teaching? And then it's like tumbleweed and crickets. Most individuals in the healthcare industry, physicians, nurses, PAs, didn't go to school to be teachers per se. So their training and the skills they have to being a teacher are limited, and often many preceptors feel a little uncomfortable with what they have to offer, or they rely on some of the skills that they were taught, usually through role modeling, which can be both great and also could be a detriment, because some of the role modeling skills that we acquire may not be ideal. So the next question I often ask is, what is the biggest challenge you face with precepting learners? And it sort of runs the gamut. There's a range of answers people say, but the biggest one that I hear more often than anything else is the idea that you need to balance patient care with balancing learner needs. So how do I do a little bit of teaching while giving the best possible care I can to my patients? So that's what we're going to try to address today, is how to do both. How to get a little teaching in so both you and your learner feel satisfied with the experience, along with providing the best patient care that you possibly can with a learner at your side. There's been several studies that have come out in the last several years about what makes a good clinical teaching encounter. And the next question I have for you is, which of the following do you feel is most strongly associated with improved learning? Okay? So here are your choices. Supervision, the number of patients seen, board scores, or the medical school you attended. Now, many of you will probably easily say it's not the medical school we attended, and probably not board scores, but number of patients seen is a provocative answer. And then you're thinking a little bit about, well, I'm sure supervision has something to do with it. So traditionally, it was number of patients seen was thought to be most correlated with improved learning performance. It was thought that if you saw enough patients of a certain type or kind or population, you would get better, whether it is taking history, taking a physical exam, doing a certain procedure. And all of that is true. However, with recent studies that have come out in the last 2 or 3 years, we have found that actually the quality and frequency of supervision that actually correlates with improved learning. So if you can couple the number of patients that a learner gets to see with the quality of supervision, which is high quality supervision, you're going to get the most bang for your buck. You're going to have a really satisfying experience both from a preceptor standpoint, and then a learner will also have a gratifying experience as well. So we're going to talk a little bit about what makes quality supervision, and that's where some of the training comes in. So what I wanted to then relate to you is that supervision and feedback is probably the strongest combination of a learning environment, the types of things you can provide to a learner, which has the strongest effect on learning. So the quality and frequency of supervision has a stronger correlation to improved performance than the number of patients seen. So the better supervision you can give, it trumps what we used to think about numbers of patients seen. And then a study came out that actually showed the converse, which just strengthens our argument, that studies have shown that the lack of supervision was most strongly correlated with adversely affecting student learning. So we know that if we can improve the way we supervise learners, we have the best shot of having improved learning. So my objective for today is, at the completion of this presentation, as busy preceptors like you all are, you'll be better prepared to implement several quick and easy teaching strategies, including the 1-minute preceptor and giving effective feedback into your daily teaching. By the end of this presentation, I hope that you will embrace the 4 strategies that I'm going to present to you today in your clinic setting immediately. They're relevant, they're appropriate to what you're doing, and I think you'll find them fairly easy to try out and get used to. So one of the things before we get started that I'd like to get us into the mind frame of what are the characteristics of excellent clinical teachers. Think back to some of your own clinical teachers, those that you probably model your own teaching behaviors after, and think about what is it that made them excellent. I'm sure some of you would probably say enthusiasm for teaching, a passion for teaching, excellent clinical medical knowledge, approachable, accessible to learners, pushed you a little bit, but not too far, but pushed your thinking and your abilities a little bit past where you were comfortable, but it challenged you. So looking at the literature, so I have a feeling a lot of what you're thinking about and what maybe you have enumerated, either physically listed or in your mind, about what those good clinical skills are, basically a meta-analysis was done in 2008 looking at excellent clinical teaching skills. And 68 articles or essays were found between 1909 and 2006. Now in 1909, there weren't medical education research articles. Those are where the essays come in. But for almost 100 years, over 100 years, we have literature that corresponds to what makes an excellent clinical teacher. And they're condensed into 2 categories, human characteristics and teacher characteristics. And I'm going to show you what those are right now. But before I do that, I want to mention that several studies, this is a rather old study in 2004, but it's been replicated year after year after year. And having taught for 12 years at UCLA and now at USC, I'm seeing the same things over and over again. And that is, in the clerkships, 3rd, 4th year medical students are reporting time and time again that they're not being observed, not being supervised. Going back to our original idea that it's really about quality supervision that improves teaching, that 49% in this particular study that you're looking at now report that they were never observed taking a history. Almost the same percentage point, almost half, 46%, were never observed, supervised, doing a focused physical exam. And 20% of those surveys said that they were never observed doing a complete physical exam. This is not unique to Los Angeles or to one hospital over the other. This is pretty universal nationally, is that supervision is lacking in all settings, inpatient, outpatient, ambulatory. And what we need to do is ramp up the supervision and the quality of that supervision in all teachable settings. Remember I talked a second ago about the two categories that all those essays, that meta-analysis of excellent clinical teaching found. And they found that there are a lot of characteristics you could point to. However, I will narrow it down to the top 5. So the top 5 teacher characteristics. Remember I said that you probably are already thinking these when you were thinking about your own experience with excellent clinical teaching. Number 1, 27 of the 68 articles said that an excellent clinical teacher maintains a positive relationship with their learners and a supportive learning environment. So keeping it positive instead of negative is kind of the key word here. Second, demonstrates enthusiasm for teaching. This is the enthusiasm you can't really teach people enthusiasm. You just come with it. This is something that you enjoy doing. You enjoy teaching. You enjoy being with learners. 3, is accessible and available to students/learners. Again, I can't teach you to be accessible or available. You make a choice that you either are or you aren't. The 4th one, provides effective explanations, answers to questions, and demonstrations. That I can give you some tips and tricks about. And that's basically what we're going to talk about today. And we're also going to talk about number 5, provides feedback and formative assessments. Feedback is one of the most underused, yet most powerful forms of teaching that any preceptor, instructor, professor can bestow upon a learner. So if you look at these characteristics, many of them are just choices you bring to the table. I just choose to be enthusiastic. It's something that's innate. So that's the good news, is that you have that already built in. If you're a preceptor, you've already decided that having a learner or learners with you is important. So the only thing that I can really do here is to give you some strategies that you can use immediately, and that's what we're basically going to focus on for number 4 and number 5. I also mentioned the human characteristics. So the ones we just saw were teacher characteristics, and they also have just basic human characteristics that are attributed to excellent clinical teachers. And those top 5 are, number 1, you're a good communicator. You communicate your priorities, your expectations. You communicate, that means feedback, and what you want out of a learning experience. And you also ask and solicit feedback, goals and objectives from the learner. So being able to have a dialogue is important, number 1, in fact. Number 2, you act as a role model. You act as if you are always being watched. And learners watch everything we do. They watch how you introduce yourself to the patients. They watch when and how you wash your hands. They watch how you drape a patient for an exam. They watch how you address them. So every moment that a learner is with you is a teachable moment. So being a role model is really important. Here comes enthusiasm again. Number 3 is an enthusiastic person in general. So you enjoy what you do, and that comes across to learners. 4 is personable, meaning you have a certain friendly disposition or demeanor that a learner could come up to you and ask you some questions, even if they feel it's a stupid question or they know you're busy, but they have some questions for you. You can say, that's a great question. Maybe at the end of the day, we can revisit that if it's a busy time. But being able to approach you, being personable. And also having a vested interest in your learner, finding out a little bit about them, what field they're planning on going into, what they find interesting, and what they would like to learn about. And finally, compassionate and empathetic. Now, of course, I would assume that you don't go into healthcare if you are not compassionate and empathetic. And your goal is, as a physician, I would assume, and I think most of you would agree, is helping people in and of itself makes you an empathetic and compassionate person. So what do learners want? And what we find time and time again through surveys at a local level, including even more global. So the literature, the current literature, say learners want more. Medical students and residents report locally and nationally that they do not receive adequate and appropriate supervision. Even at my local institution, the last survey that was given by the accrediting body for residency programs showed that one thing that residents really didn't get and wanted more of was appropriate and adequate supervision. And again, that we need to talk about what that means. And I think the 1-minute preceptor will help us answer that question. The other thing learners want more of is feedback. They do not receive enough timely and useful feedback. Again, we need to really define what that means, and we will go into that in a little bit. But the idea that they're not getting enough may be a perception issue. So you may say, and this is what I find very interesting, I call it the feedback gap. So learners say they don't receive enough feedback. And what do you think preceptors and what do you think faculty say? They give it all the time. Every time I talk to faculty and preceptors in our community, they say I'm always giving feedback. I'm always telling them what a good job they're doing. I'm always commenting on their write-ups. I'm always commenting formatively and summatively. So what accounts for this gap? That's the question. Learners say they don't get enough. Preceptors and faculty say, I give it all the time. So that's why I think it might be a perception issue, is that learners often don't recognize feedback when you're giving it. There's also a perception that feedback has to be formal. So it has to be written down sort of officially on some form. It has to be negative, critical. It also has to be you and the learner behind across from each other in a quiet room, behind a desk. That it's this sort of formal atmosphere is when a person receives feedback. I don't always think that learners know that they're receiving feedback when, A, you give them praise. 2, those moments where you're at the bedside of a patient, you're in the exam room, you're walking down the hallway, you're in the elevators, you're having coffee, and you're giving them comment and reacting to something you saw them do. I don't know that learners automatically see that as feedback. So here is my first strategy for you today. Number 1 strategy, and this is going to feel perhaps awkward, maybe inauthentic, but I'd like you to give it a try and see if your learners feel they're getting more feedback. Ask them, after trying this for a week, if they feel like they're getting more from you. Strategy number 1, start any discussion where you plan to give feedback with the phrase, the feedback I have for you is, ... The idea is that even if you don't phrase it that way, but you pepper that word feedback into your conversation or dialogue with your learners, the little light will go on. Oh, I'm getting feedback. And even if it's praise, like I thought you did an excellent job establishing rapport with that patient, so my feedback to you is to continue to do that. Good eye contact, leaning in, asking open-ended questions. My feedback for you is you did a wonderful job doing that. And you can also do that with corrective feedback. I don't like to use the word negative. I think negative has its own connotation of being bad or wrong. If you use a word like, I have some corrective feedback for you, even constructive criticism has its own kind of slant. I like the word corrective. So even when you're giving corrective feedback, you can always throw in, so my corrective feedback for you is, you might want to try it this way next time. Or what I have found helpful is I've tried it this way. So my feedback for you is next time, please try it this way, and we'll talk about the different strategies. So this is one way to get the word feedback into all of your conversations. How simple is that as a strategy? doesn't take much, and all you have to do is say the word feedback. And I do think what we have seen sort of anecdotally is that this has helped with learners' perception of receiving feedback. The second strategy is priming the learner. What we mean by priming the learner is it's a quick and easy strategy to orient your learner, to provide some expectations prior to the learner going in and seeing a patient. What this does is it gives the learner a framework in which they can work in, and when they come out to present the patient to you, you're getting the information exactly what you want. They're not feeling like they're all over the place. You're also giving them a bit of a time frame. So 15, 20 minutes with a patient, they know that they need to do some focused history taking or physical exam procedures. So priming the learner prior to going into a room. Now, of course, this is usually done with trainees early in their careers, third-year medical students, fourth years, maybe even interns. You want to orient the learner to the patient prior to the encounter. So presumably the patients that come into your clinic, your office, are ones that you have a prior relationship with. And that may not always be the case, but in certain situations you may have already seen this patient in the past and might be able to give your learner a 1-minute orientation to this person. So in doing that, you provide some context, some past medical history, perhaps what the chief complaint is. If you happen to know that, you can look at the chart and give a learner some idea of what to focus on in that exam room. What you should do is review the patient's medical background, tell the learner what complaint to focus on, set some guidelines for the physical exam, and then set a timeline or a time limit on that initial encounter. You want to make sure you communicate. Remember, communication being one of those top human characteristics of excellent clinical teaching, communicating your priorities for learners before each patient interaction. If you communicate what you expect, you'll be, I think, pleasantly surprised that learners will actually meet and exceed what it is you expect from them. If you say, well, what if I don't know this patient? This is a new patient to our clinic. I don't have any orientation to give my learners. And I hear this question a lot. What I would suggest is that you model for your learner how you prepare to go in and see a brand new patient. What it is that you look for in the paperwork, in the chart, how you would go about thinking. Now, of course, you're experienced. You do this a mental model. You have a mental checklist. But if you could verbalize, talk aloud to your learner how you prepare to see a brand new patient, what you think about, you're capitalizing on a very important skill that often is overlooked. So what we're going to do now is I'm going to actually play 2 videos that illustrate the idea of priming the learner. Now, for those who are listening, you're going to get to hear the audio. So our first video illustrates the first encounter with a learner and a preceptor overseeing a patient. So listen to what the exchange sounds like and what they say to each other.
Keith, this is Mr. White. He's a gentleman I've been taking care of for the last 10 years. He really has some interesting physical findings. What I want you to do is spend a few minutes with this chart here. You've got about 10 or 15 minutes. Go in and characterize his chief complaint, do a brief examination on him, and then come on back and let me know what you think, all right? But by the way, volume 2 of his chart's on my desk, and you need to take a look at it, okay?
So what that video clip illustrates is a preceptor rattling off a bunch of orders to a learner, handing him a chart that's like this thick, telling him to spend a few minutes with him, characterizing the chief complaint, come back and see him. And then volume 2 of that thick chart is on his desk. So what you're essentially telling the learner is go ahead and dig through piles and piles of information and paperwork to get to the information you need. this wastes a lot of time and it slows down the clinic environment. So by you priming the learner, you save a lot of time and you actually can use the learner to the benefit of the clinic flow. So by giving him that overview of the patient, you then give them exactly what it is you would do, what you want them to focus on. So when they come out, it's a more productive case presentation of the patient when they come out of that exam room. So another video, let's see if we can do a little better here with this video vignette of priming the learner prior to seeing a patient.
Keith, this is Mr. White. As a gentleman I've been taking care of for the last 10 years. I think you really like him. He has a history of hypertension. He's had some reactive airway disease in the past that's been well controlled with inhalers. A couple of years ago, he had his aortic valve replaced, and he has pretty interesting physical findings in terms of his cardiac exam. He also, in the remote past, has had an exploratory laparotomy. It looks today that he's here with some abdominal pain. So what I want you to do is go ahead and spend about 15 or 20 minutes with him. I'd like you to characterize the chief complaint, do a cardiac, pulmonary, and abdominal exam on him. Come back and find me and let me know what you think, all right? Okay. Sorry, this is Jarvis.
Okay, so what was illustrated in that video clip was, and it took less than a minute, to explain to the learner that this is a patient he's seen for many years, gave him a little bit of the past medical history, said the chief complaint. You know, it looks like he's here for abdominal pain. Good. So I want you to characterize that chief complaint. 15, 20 minutes, gave him a timeline, and also said I want you to do a focused physical exam. I want you to do a cardiac, pulmonary, and abdominal exam. So the learner knows what to focus on and doesn't waste the patient's time or the preceptor's time. And they're also learning how to get to the heart of the matter. One thing it may have sort of flown by, but the preceptor also set up sort of the context in terms of a tone. He said, I think you're really going to like this guy. So the learner goes into the exam room already with an idea that this is going to be a guy he can really relate to. He'll be interesting, and he'll probably be a good conversationalist. I think you're really going to like this guy. And that really does, that one little phrase really does help the learner put them at ease. And it could be the opposite. It could be, you know, this patient's going to be a little difficult, so I want you to focus the patient on the question. That little bit of information, priming the learner, is really helpful. So if the learner knows that this is a difficult patient or tends to go on tangents or is a really chatty person, but you only are giving 15 minutes to find out what's going on, at least the learner is armed with that information and will be able to redirect the patient back to the actual history. So that's priming the learner. It doesn't take very long, and it really does set the expectations. So the next piece we're going to talk about is what happens after. That means after the learner has seen the patient, they've done presumably everything you've asked them to do, and they're ready to come out into the hallway and present the patient to you. So there is an article called Teaching When Time is Limited in BMJ, the British Medical Journal, 2008, I believe, and it highlights, it's by Dr. David Irby and Luann Wilkerson, and they highlight these 5 teaching techniques. It's a great article that gives you some real concrete strategies and techniques you can use in the clinical setting. So we're going to talk about the 1-minute preceptor, our third strategy today. There's also these other strategies that if you're interested, you can certainly look up this article and learn more about the Ant-Mini model, SNAPs, activated demonstration, and case presentations at the bedside. But for our interest today, we're going to talk about the 1-minute preceptor. The 1-minute preceptor is probably the most widely known and researched teaching method that exists for clinical teaching. So research on the 1-minute preceptor over many years, it's I think now in its second decade of being used, and was developed by Dr. David Irby when he was at UC San Francisco. But what we have found from medical education research on the 1-minute preceptor is that there is strong happiness data but basically it means that both the learner and the preceptor are very satisfied with this model. So that's at least we know that when it's used, everyone gets a little something out of it. The preceptor gets a better flow in the clinic and feels like they're actually doing some teaching and making an impact, and students feel like they're getting entrustable activities and they're getting the feedback they need to improve. It is also shown to improve faculty and resident teaching ratings after the students were observed and provided feedback on the basis of this model. So what's great is if you're in a setting where evaluations matter, this model has shown, has been proven that there is statistical significance between teaching before you were taught the 1-minute preceptor and after. So that can be really, I think, encouraging for many preceptors and many of our faculty, especially when evaluations are important in certain settings. So what is the 1-minute preceptor exactly? So it involves identifying the needs of each individual learner. So that's great. That's the first thing the 1-minute preceptor does. Secondly, it provides space for a little bit of teaching, little bit being the optimal word, and providing feedback by using a 4-step approach. They're very simple steps, and you can mix the steps up in any order you like. But this is how it was introduced originally by Dr. Irby. The first step is get a commitment from the learner about what the learner thinks is going on with the patient. Get them to commit. This is a very important step because you're looking at their ability to make a decision and commit to something. It may be wrong. They may be way off, but the idea is that they're willing to go past, I don't know. I don't know is not an acceptable answer in this model. They have to come up with something. And even better, a differential. They can come up with 1, 2, or 3 possibilities of what's going on with this patient. So get a commitment is number 1. Number 2, probe for underlying reasoning or alternative explanations. So what you're doing here, again, you're identifying the learner's individual needs. What is their level of training, their knowledge, unable to rationalize or reason through the differential diagnosis? So why do they think this is going on with the patient? What evidence can they show you, can they tell you about that points to this being the correct diagnosis? Again, they don't have to be right, but they have to be thinking in that way. And that helps you identify the learner's needs, and it also shows the learner that this is something they can count on from you and they're more prepared. Third, teach a general rule. What this means is that you get to teach one rule, not a lot of general rules. It can be anything that you think the learner needs to know that they're maybe missing from the explanation they gave, from the probing you did of their rationale. You may teach them something that may lead them to think about a different diagnosis. But the idea is that you teach them one thing that's really crucial or important to this particular patient or case or diagnosis that you think that they would benefit from learning. It's also not to overwhelm them with a lot of information. It's one thing that they can really kind of stick in their repertoire. And finally, providing feedback. You want to provide positive or praise about what was done well, but you also want to correct errors and make suggestions for improvements. We know that no matter how good you are, how many years you've been doing clinical teaching, clinical education, we can all improve. So there's always something that a learner can improve upon, but they also probably did something very well. And you want to make sure that you provide your learner with that feedback as well. So if you can see these 4 things, what you're doing is you're getting a lot of information out about the learner and the patient. So what we say often in medical education is that the 1-minute preceptor helps you diagnose the learner and the patient at the same time. But you need to be aware of some pitfalls, and this is what many of us fall into when we're doing case-based teaching, especially in a very busy clinic environment. There's many things that we just sort of fall into by default because this is either how we've always done it, or we're in a rush, or the learner isn't coming up to speed fast enough. Here are some of the pitfalls that we have identified over the years as potential challenges for our preceptors to overcome. Taking over the case. So the learner starts to give you the case presentation, but they're either they're going too slow for you, or they're on the wrong trail, their thinking is flawed in some way, that you just take over. You take over the case because time's a factor and it's just taking too long. But if you ask the right questions and you use the 1-minute preceptor, you don't have to take over the case. Inappropriate lectures. And what we mean by that is you realize that this learner doesn't know something, and you feel it's your obligation or your duty to give them a lecture on this topic, on what causes edema, or what's the differential diagnosis of fever. You give a little mini lecture. I can tell you that's not beneficial for your time, your clinic, and most likely the learner's not going to remember 90% of what you said. So inappropriate lectures are often something we would try to avoid. Insufficient wait time. And what we mean by that is when you ask a question, you need to actually wait 3 to 5 seconds, or longer perhaps, for the learner to process what you asked and think about an answer that would be appropriate. So instead of they're not coming at you fast enough with the answers, the idea is that give someone a second. And if they look like they are not on the right track, to actually say, do I need to clarify? Let me rephrase the question. What don't you understand about the question? So asking your learner another question instead of answering it yourself. Pre-programmed answers is fairly common. You're basically giving them the answers by saying, so do you think it could be an ulcer? What do you think about cancer? What about gastritis? What about this? So you're leading the learner to the answers that you would like to hear. So those are sort of pre-programmed answers that we would like you to actually say, well, what do you make of some of these physical findings so that they are led down the road instead of you giving them the actual answers. And then rapid reward. It ends the learner's thinking process, and it often is seen as insincere. And what we mean by that is before you're even done listening to the presentation, you say, good job, pat on the back. It doesn't really give the learner much to hang their hat on. It doesn't say what they did a good job on, why it was good, what you want them to do in the future. And it often comes across as you're brushing them off, or you just want to move on to the next patient, the next case. So think about really thoughtfully the types of positive or praise you want to give your learner. And finally, pushing past their ability. So you want to push your learner, challenge them to think past what you think they're capable of, but not too far past where it is way too advanced for them, and then they end up feeling discouraged. So certainly think about challenging your learners and asking them some provocative questions, but not marginalizing them by asking them questions that you know is for, more of a third-year resident or even an intern at a third-year level you're dealing with. So those are some pitfalls. So what we're going to do is we're going to actually look at some videos that illustrate some of these pitfalls. So these are the what not to do's. But then we're going to end with an example of the 1-minute preceptor done the best this preceptor in this video vignette is going to do. The first clip is going to be the longest, so bear with me. It's about 2.5 minutes. Because it's going to be Keith, our third-year medical student, coming back out after seeing, remember, Mr. White, and giving his case report, his patient presentation to our preceptor, Dr. Ferenczek. So the first video is going to have that patient presentation, and then we will see the preceptor responding to that. The subsequent clips, the 3 subsequent clips, will not include the patient presentation. So we're going to take a look at those. All right. Here's our first clip. Again, this is the longest at, 1 minute and 53 seconds.
Dr. French, I got seeing Mr. White. I'm ready to discuss them with you now.
Okay, why don't you go ahead, Pete?
He presents today with intermittent abdominal pain over the past 3 months. The pain is described in the upper abdomen, and he describes it as a burning sensation. Initially, it was relieved by food and with antacids, but neither of those are working currently. He still drinks alcohol, but he quit smoking about 10 months ago. He's also concerned about some weight loss he's had over the past few months. As you know, he has a history of aortic valve replacement, as well as an open laparotomy and colitis, but all of those are currently quiescent. His medications currently include enalapril for hypertension, as well as some inhalers for reactive airway disease. He denies any NSAID use.
Okay.
On physical exam, Mr. White has a blood pressure of 146/48. His pulse is 80 and regular, and his respiration is 12 per minute. His weight is down about 12 pounds from previous documented weight, and his HENT exam is within normal limits, as was his lung exam. The abdominal exam reveals active bowel sounds and is generally dull with percussion. Palpation reveals reproducible tenderness in the epigastric area without rebound rigidity or masses. His liver and spleen are of normal size. His rectal exam reveals a prostate of normal size and a hint of heme positivity in the stool. I'm really not sure what to do with this patient.
Okay, from what you tell me, it sounds like this may be more than just your garden variety dyspepsia. Certainly the history physical examination findings that you have obtained from this patient suggest the possibility of peptic ulcer disease. However, with the weight loss and the heme positivity to the stool, I am concerned about the possibility of a malignancy, particularly a gastric carcinoma in this patient. So before we go ahead and commit this patient to therapy, I think we need to get some liver function tests on him. I get a PVC and some coags. Let's order a platelet count as well. Send him up for an EGD, and we'll see him back in about a week, okay? Okay.
So, typically at this point, I'd be asking you, what do you make of that preceptor? What did he do? What was that an illustration of? That was a perfect illustration of taking over the case. The student, the learner, did a really nice job organizing the information from the patient, presented exactly what the preceptor had asked him to present, and find the information that he wanted him to find. And our preceptor decided he knew what was going on with the patient and just took over the case, didn't ask our student any questions whatsoever, didn't give him any feedback about the presentation that he just gave, and then said, we want to set him up for these labs, we're going to get coags, we're going to get these, blah, 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 blah. And what happens is the student is just sort of like inundated with information, most of which he's probably going to have to ask the preceptor to repeat. So taking over the case doesn't help anyone because it probably actually will cost the clinic more time. And the learner is just basically a gopher. So let's take a look at another video that illustrates another one of these pitfalls that I had mentioned.
I'm really not sure what to do with this patient.
Well, Keith, I can't believe you didn't think about the possibility of gastric cancer in this patient. Clearly, gastric cancer is much less common today than it has been previously. However, proximal gastric carcinoma, that is, that near the GE junction, is clearly more prevalent today than it has been in times past. Unfortunately, that has a pretty bad prognosis. In addition, there's such a thing as superficial gastric carcinoma, that is, gastric carcinoma that has not penetrated the submucosa. It's not very common, but fortunately has a pretty good prognosis. Okay? Unfortunately, only 5 to 10% of the patients who have got gastric carcinoma have superficial gastric carcinoma. So what I'm going to do is go into the room, see Mr. White with you. Okay? We'll get a management plan for him, and afterwards I want you to go and read about gastric carcinoma in Harrison's textbook. Okay.
So again, I would challenge you to identify what pitfall this was illustrative of. Well, first, he belittles the learner and says, I can't believe you didn't think about the possibility of gastric cancer in this patient. So that's not going to help learning in any way, to belittle your learner. But then he goes off on this inappropriate lecture on gastric carcinoma, superficial gastric carcinoma that has not penetrated the submucosa, I mean, get ready to glaze over. So basically what has happened there is, again, the preceptor has inundated the learner with a bunch of information about a carcinoma that the learner is only going to get a fraction of that information in, and he didn't ask him anything and gave him no feedback. So let's see if we have another example. We do. Here's another example of another pitfall that I mentioned earlier.
I'm really not sure what's going on with this patient.
Well, Keith, what do you think could be going on with this patient? Do you think it could be an ulcer? What about gastric cancer? What about gastritis?
It could be.
Good, Keith. You're really starting to get a handle on this differential diagnostic process.
Often that one gets a little bit of a chuckle. We're actually rooting for the preceptor at this point, and when he says, well, what do you think could be going on with this patient, Keith? You're like, yes. But he actually doesn't wait, insufficient wait time. He answers his own question and then has some pre-programmed answers. Well, do you think it could be this? Do you think it could be that? Essentially giving the learner the differential diagnosis list. And then finally, gives him a compliment that he really doesn't deserve. Good, Keith, you're really getting a handle on this differential diagnostic process. And that basically points to rapid reward. So all of those illustrations show you some pitfalls. They're very common, and you probably recognize yourself in some of those. But a good way to turn this around is using the 1-minute preceptor and those 4 steps. So the final clip is going to be an illustration of the 1-minute preceptor being used.
I'm really not sure what's going on with this patient.
Keith, what do you think could be going on with this patient?
I think he might have an ulcer, and I'd like to treat him with an ACE2 blocker.
Okay. And what led you to that conclusion?
Well, it was primarily the location of the pain and the relationship between the food and the acid therapy.
Okay. Any other thoughts come to mind?
Well, we need to consider esophagitis and other inflammatory diseases, and we also need to consider H. pylori at this point.
Okay. Really good, Keith. I think that your assessment of this patient's problem based upon the history and physical examination items that you collected is quite accurate. And certainly his smoking history and his alcohol use put him at risk for the possibility of inflammatory disease, including ulcer disease. However, I'm a little concerned about the weight loss, and that in conjunction with the heme positivity to the stool makes me wonder about the possibility of a gastric cancer. Okay, so before we commit this gentleman to therapy, I think what we need to do is consider the possibility of ruling that out, possibly with an EG, being more confident in the therapy that we're going to be able to put him on. So what I'd like to do is let's go back in the room. Let me ask him a few questions, do a quick examination on him, and then we'll discuss the management plan with him. Okay. Very good.
So that's an example of the 1-minute preceptor. I would offer up that our preceptor could have actually asked our student, our learner, a few more questions. Instead of coming up with the management and treatment plan himself, he could have asked him a few more questions. However, in the interest of time, and it being, in fact, the 1-minute preceptor, you probably noticed that the preceptor asked the learner to commit. What do you think is going on with this patient? And the learner gave several possibilities, and he said, and then our preceptor asked anything else. And he said esophagitis and H. pylori. So he committed to several different things. And then he asked them to back up his commitment with some evidence. So I believe he said the pain in relation to the food and acid therapy. So he gave some evidence or some rationale for why he thought that way. Now, a lot of people don't always catch the teaching of the general rule, but what it was the preceptor mentioned that when you tend to see a 20-pound unintentional weight loss in a patient like this with his history of alcohol use and smoking, your differential should include cancer. And our student didn't have that on his differential list. But with the weight loss and some history findings, that should have been one of the things on the differential, and that's the bit that our preceptor taught, a general rule. So when you see weight loss of that magnitude in a short period of time, you want to consider carcinoma or cancer. And so that's a general rule. He also gave him some feedback. He said, I think your characterization of the pain is quite accurate. And so that was his praise or positive feedback. But he also said, in correcting him, in teaching him a little bit about the idea about having cancer on the differential list, that was also part of the corrective feedback. So next time, think about this when you hear a patient present some of these findings or some of this in his history. So essentially, we could probably do a little better. Some more teaching could be added in there, some more questions from the preceptor. But for illustrating what the 1-minute preceptor is, this does a good job of it. So now we're going to move on. I've already done all of these. Let me move on here. So now what I would have asked many of you to do is, if we had a full house, we would do some role plays with some vignettes. And so what I'm going to do is I'm going to read or show you and read a vignette, and I want you just to think about how you would be the 1-minute preceptor, how you would perform the 1-minute preceptor in this instance. So I'm just going to read this. Pardon me. Okay. So just imagine this. Sit back and let me read this to you. So I just saw Miss Fitzgerald, a 62-year-old female with a history of controlled hypertension and a 42-pack per year smoking history. She is here today for 2 days of fevers, diffuse malaise, and cough productive of rusty-colored sputum. She also notes sharp, non-radiating right side chest pain, made worse with coughing and deep breaths. Her symptoms have not improved despite using Tylenol PM remedy last night. She has never had these symptoms before and reports no recent sick contacts. On exam, her temperature is 101.2. Her pulse is 110. Her respiratory rate is 22. And her blood pressure is 104/72. Her O2 saturation is 87%. She is in mild respiratory distress and is diphoretic. I also noted bronchial breath sound with crackles in the right mid-axillary line. I'm really not sure what to do next. So what you want to think about is, what would you say to this learner using the 1-minute preceptor as your framework? So you would probably ask me at this point, what do I think is going on with this patient? What are my ideas about a possible diagnosis, differential diagnosis? And I would, knowing your expectations as a preceptor, be giving you a list of possibilities of what's going on with this patient. You would then ask me, why do I know this? What led me to that conclusion? What evidence do I have in the information I just presented to lead me to that conclusion? And hopefully I would provide some evidence from the information I just gave you that led me to give you 2 or 3 possibilities of what's going on with this lady. I would definitely highlight some of the pertinent positives and the pertinent negatives in this vignette. I would then expect that if I was missing something or I failed to give a possible diagnosis, that you, the preceptor, would then chime in with teaching me something that I could hopefully take forward with me when I see patients that are similar. And then finally, you would give me some feedback on maybe how well I presented the information, or my differential diagnoses. Maybe they were all what you were thinking. Maybe you like how I connected the information that I gathered with the differential diagnosis, and then also give me some corrective actions. So things that I can think about the next time I see a patient similar to this, or what I might be wanting to think about in the future. So that's kind of how the 1-minute preceptor would unfold, and it really should take only about 1 minute, and that's a great time and cost saver for you in the clinic. So let's go back to our presentation. So just to reiterate, you get a commitment, you probe for underlying reasoning, you teach a general principle, and you provide positive and corrective feedback. That's the 1-minute preceptor, and I think it's something you probably can try out immediately this afternoon, tomorrow, this week, with your learners in your clinic. So I just want to give some last words on feedback and the importance of giving feedback before we wrap up. I mentioned earlier that it's one of the most powerful yet underused instructional strategies available. It takes less than a minute. And several of the above models, those 5 models I had listed before, build feedback into the sequence. And most notably, the 1-minute preceptor, feedback is highlighted pretty prominently in there. Feedback provides the learner with a description of their strengths and recommendations for improvement. They need both of those to feel like they've got the information to move forward. Both they know what to continue to do, that they did well, but what they may want to think about trying or doing differently in the future. And make sure you go beyond praise to specific descriptive comments about the learner's performance. So not just good job, but what about it was a good job. I always say use a lot of adjectives. Try to say, you did a good job of this because. My feedback for you is the rapport you had with that family, or your show of sensitivity, or the way you, did the fundoscopic exam was outstanding because ... So really try to fill your feedback with lots of specifics. Finally, it serves as an opportunity to promote self-reflection and independent study. There's nothing wrong with you saying, well, how do you think that encounter went? Have your learner actually self-assess. And this really does promote self-reflection, and you're able to also, again, identify a learner that's able to pick up on their own inadequacies, but also the things that they're good on. And you can also say, well, why don't you go look that up? Or, I don't know the answer to that either. Why don't we go look that up together? Or would you mind finding out about that and telling me a little bit about it tomorrow? So this is a really good ongoing learning. Learning doesn't stop when that patient is gone or the day of, clinic day is over. We often find that the feedback sandwich, all of us have heard about the feedback sandwich. And this is what used to be typically what was used to give feedback to learners. And it was what was done right, then the meat, what needs improvement, and then what was done, another praise. It was praise or positive, negative, positive was the feedback sandwich. I would like you to think about the feedback sandwich in a different way. What was done right, what they could do differently, and what to do next time as the feedback sandwich. I do encourage you, I mentioned earlier, a slide earlier about self-assessment with your learners. Giving feedback and encouraging students to reflect on their own performance, you as a supervisor, as a preceptor, really do have a positive effect on learning. You can ask them, what do you think went well in that situation? What would you do differently next time? And how are you going to make those changes? Simply doing those 3 things, and you could add those into the 1-minute preceptor pretty easily by asking them to self-assess. You really get, it feels like a team and a dialogue in terms of learning. And feedback and reflection are basic teaching methods of clinical setting. Unfortunately, they are generally underused. So, strategy number 4, we're at the end of our presentation, but I would like you to try asking your learner to provide themselves with their own feedback. And you're there to guide, facilitate, agree, disagree, augment what they say. So ask the learner to rate, discuss, express how they think or felt an experience went. Ask the learner to explain what they did well, and then ask them what they might want help with, where they were not as confident as they would have liked to be, or maybe something they'd like to learn about for next time. If you ask that, and it may not always happen with the 1-minute preceptor, but think about doing this at like a mid-rotation feedback session, or even when you get to know them in the very beginning. Ask them what it is that their strengths are and what they want to improve on with their time while they're with you in this particular experience. So to summarize, I've given you 4 strategies that you can use immediately in your clinic setting. So number 1 is probably the easiest, and that is the feedback I have for you is ... or again, peppering the word feedback into your comments to your learners, closing the perception gap between you giving feedback all the time and your learners wanting more. Second strategy is priming the learner, giving a framework or expectations to the learner about the patient prior to going into the room. And it really does help set up the learning for when they come out and are ready to present the patient to you. And then you are armed with the 1-minute preceptor. So you now have this 1-minute strategy that allows you to diagnose your learner and your patient, teach a little bit, and give feedback. And finally, strategy number 4 was ask your learners to self-assess, to give themselves some feedback. So it's not all on you as the preceptor, but you're also promoting a learner that is actively involved in their own assessment. And I think you'll find that it'll be a very satisfying experience if you try all of these, but I hope you'll at least try one of these in the future. Thank you, and if you have any questions, I'd be happy to answer them now.